Thank you so much. And thank you so much for the kind invitation. It is truly a privilege to be invited to sit at the table and to learn from all the experts present today. Um, I'm Natalie and I'm from the National Heart Centre in Singapore. And thank you for inviting me to speak about gender and cardiovascular health and to discuss some of the reasons why women are left behind. Think this is not news to us that there is a silent epidemic when it comes to cardiovascular disease amongst women globally. Cardiovascular disease kills more women than all cancers combined, and this was known from 2011, and nothing has changed 10 years later in 2021 when Lancet published their Lancet Women and Cardiovascular Disease Commission. Nothing had changed in all these years. Women remain underdiagnosed, undertreated, and underrepresented in research. And I think there are many studies that have proposed various reasons why. And we can look at it from both a biological as well as gendered risk factor perspectives. Some of the biological differences include sex-specific risk factors, such as pregnancy-related complications that was fervently discussed in the previous talk. Known risk factors include women who have had to endure preeclampsia, gestational diabetes, pregnancy-induced hypertension. Other sex-specific risk factors include early menopause and women who have autoimmune disease, such as lupus and rheumatoid arthritis, which affect women more than men in a ratio of 4:1. Unique pathophysiology to women include their later presentation of CAD, coronary artery disease, in their postmenopausal years, spontaneous coronary artery dissection, microvascular angina, and MINOCA, which has received some headlines in the last 2-3 years. Specific gendered factors include social cultural barriers and systemic biases in various healthcare systems, not just unique to, I think wherever we come from in the various healthcare systems we represent, whether it's Australia, Pakistan, or Singapore, I think this is quite common and we see anecdotally in our practice. There tends to be delayed care seeking among women, sometimes some provider bias as well. And importantly, what is borne out in the literature and well published is that women are also more likely to present with non-chest pain symptoms such as fatigue and nausea. And the American Heart Association, since 2019, has been doing lots of public outreach. This is one of their publicity material to inform providers as well as patients, potential patients, that not everyone presents with chest pain when it comes to a heart attack. For women specifically, they tend to present not always with chest pain, often a pressure or a pain in the lower chest or upper abdomen, frequently simply nondescript findings of shortness of breath, some fainting, perhaps indigestion, or simply fatigue. Then there is also the research gap that contributes to this silent epidemic, and historically, clinical trials have excluded women or failed to analyze sex-specific outcomes. I'm so grateful to learn that Dr. Anna Beale, in the course of her PhD work and with various consortiums, has done so much to address this gap. Many congratulations for the excellent work presented, especially to HFpEF. And even in preclinical studies, in phase 1-2 trials as well, often male animal models are used, skewing drug development right from the beginning. And it's also reported in the literature, adverse drug reactions are actually more common in women because they were not tailored for women, and it began even in preclinical trials. So this is a study by Accenture, just published 3 months ago, specifically to draw your attention to the cardiology trials, coronary heart disease. Only at best, 35% of trial enrollees were female. And in terms of reported disease cases, despite the underrepresentation in trials, women accounted for 44% of the adverse outcomes. There are also disparities in care, and we know from the literature that women are less likely to receive statins, revascularization, or even guideline-directed therapy. In one study, only 54% of women with heart disease received cholesterol-lowering medication versus 74% of men. And in this study, The questionnaire actually revealed that perhaps implicit bias and age-related comorbidities compounded these issues. And the cost of being left behind, starting from research and even, from the root of the studies all the way to the implementation in our clinics and the social biases, means that there is greater mortality and morbidity in women post-MI. This reached the headlines, I think, 2-3 years ago in ESC. Women are more likely to die from heart attack. Obviously, delayed diagnosis leads to worse outcomes and ultimately higher healthcare costs. And many studies from patient survivor groups have actually reported the emotional toll that women feel having been survivors. They often feel dismissed or unheard in clinical encounters from the start and in continuity. This is a study that actually also was from the same Accenture paper published 2-3 months ago that showed the worst outcomes because of delayed diagnosis in women. So I will conclude shortly by presenting one of my patients. She was asymptomatic and she was referred by our national healthcare system to the cardiology clinic. She was 62 years old because her general practitioner found that she had some ischemic changes on the ECG. Specifically, she had some T-wave inversions in the anterior leads, V1 to V6. On serial repeat ECGs, these persisted. They were non-specific and not dynamic. She had no classical symptoms of chest pain. Of note, she had dyslipidemia, suboptimally controlled with LDL of 3.8. Her home blood pressure showed a systolic blood pressure consistently between 120 and 130. In terms of her family history, of note, her father had passed away suddenly at the age of 40. So I offered her some either a functional assessment or a CT coronary angiogram because it was important that her family history was significant. She had some risk factors. She was postmenopausal, although she did have pregnancy-induced hypertension. After a discussion, she chose to do a treadmill echocardiogram because she was not so keen to have any IV plug setting. The stress echo was negative for ischemia, but the stress ECG was quite positive, showing ST depression in 2-3 AVF, horizontal ST depressions at peak, 2 mm that persisted into recovery, although she was largely breathless without any chest pain. So I took a further history from her, noting the functional assessment findings, and she's continued to dismiss her symptoms and said maybe she felt a little more tired when carrying her grandchild and perhaps a little more breathless when carrying some packets of rice from the market home. Again, generally continued to say she felt generally well. But I was anxious and we discussed the discordant findings and I advised a more sensitive modality such as the CT coronary angiogram, to which she eventually agreed. And it actually showed this. We see that there is very calcified lesion in the LAD, but more importantly, there's high-risk plaque across the proximal, mid, and distal RCA. You can see that on the right, non-calcified plaque with positive remodeling. And this was what the diagnostic angiogram showed, significant disease in the RCA. Ultimately, it was decided that she would receive her stents because of her symptoms, which on table, she said actually she's been having a little bit more exertional symptoms, although a reasonable alternative could have been a trial of medical therapy, especially because this was non-left main disease. So what are some of the takeaways from this 62-year-old seemingly asymptomatic patient of mine? I think as physicians, we need to have a high index of suspicion for coronary artery disease, especially in women when there are relevant findings such as ECG, presentations, gender-specific risk factors such as pregnancy-induced hypertension, positive family history. And when tests show discordant findings, we should look at it again and perhaps consider a more sensitive modality if the burden of risk favors that option. And of course, we would need to reinforce strict adherence to goal-directed treatment therapy, reinforce this need and not shy away from the doses of medication it would take to reach the target LDL, knowing based on multiple sources of literature that women tend to be undertreated from the medication adherence perspective all the way to the revascularization. So what really needs to change is it starts from research, I think Dr. Beale presented beautiful research to us, and we need more of that. Inclusive research designed with sex disaggregated data. The providers, doctors need education on gender-specific presentations, especially when it comes to coronary artery disease. And women don't always present with typical chest pain. We need policy-level changes to mandate equity in funding and trial enrollment. And when more mature, when the ecosystem is more mature research-wise, we should also reinforce set-specific risk calculators and diagnostic algorithms. And of course, tailored prevention strategies with calibrated risk when it comes to detecting coronary artery disease in women. And moving ahead in an era of AI, generative AI included, and precision medicine, we would be in a better position to deal with big data sets and perhaps tease out the differences in gender to allow us to tailor gender-specific risk prediction. We would want to engage in awareness campaigns targeting both clinicians and the public, and this initiative today that we are invited to participate in, I felt strongly about, and many thanks to the organizers for inviting me to be part of this campaign for women, to advocate for them. And we would like to build interdisciplinary collaborations and cross-border collaborations between specialists and between healthcare ecosystems to continue to uplift women and give them the spotlight that they deserve to overcome this silent epidemic. And with that, I thank you for your time and would like to invite any questions.
Thank you, Dr. Natalie.